keratoconus. What are these high modulus lenses? They are nothing but stiffer lenses. We all know that if you put a soft contact lens on an irregular cornea, it will get molded up and it will not be stable. But these high modulus lenses means they resist the deformation. And also there are piggyback system of lenses. The newer innovations which are coming up are the wavefront guided lenses, the 3D printed lenses, and the smart contact lenses. So what are these? What are the wavefront guided lenses? See, we will be correcting the lower order aberrations like the myopia, astigmatism and all with your spectacles or contact lenses and all. But a lot of higher order aberrations are happening on the irregular cornea. So a wavefront aberrometer will capture the unique fingerprint of the eye, including these higher order aberrations, and data from these wavefront scan is used to manufacture the contact lenses. They will be tailored to correct specific aberrations for that particular patient. They will provide sharper, clearer vision, especially in low light conditions, and improved optical performances. That is what a patient with irregular cornea needs. And future directions are integration with artificial intelligence, wavefront guided daily disposable lenses, combination with smart technology. But all these technologies are, the limitations are its cost and the complex fitting processes and the availability. Then another one is the 3D printed lenses, that is the three-dimensional printed lenses. What are these? These are constructed using biocompatible materials with accuracy down to microns. Like these contact lenses will be manufactured using additive manufacturing techniques. The material is deposited layer by layer, creating a fully customized lens using the corneal topography or the tomography of the particular patients for precise adjustments for the corneal irregularities. Advantages are we will be able to make personalized designs based on the patient's unique geometry. Specially made lenses for like multifocal toric or wavefront guided lenses with intricate designs. Again, disadvantage is the high initial investment and the limited availability. Then this picture shows a smart contact lens fitted with a biosensor device. That there will be miniature sized embedded electronics like an LED light or the data integrated vision enhancement systems, which will be specially used for pilots, engineers and all. And other uses may be for the macular degeneration or your RP patients, then autofocusing lenses for presbyopia and other refractive errors, drug delivery in glaucomas, and also for UV protection, blue light filtering as in your spectacles. And broader applications are a cognitive assistance for dementia patients. These are all these smart contact lenses coming up. So in severe keratoconus who is intolerant to RGP, you can offer them a large diameter scleral lens with a Walt adjustment for improved vision and comfort. And also if a patient had undergone cross-linking, there will be alteration in the curvature of the cornea. So you can offer him a wavefront guided lens with enhanced night vision and reduced aberrations. So these are all in the dream-like scenarios, but whatever it is, we will be coming up to our reality. Future directions in contact lenses, improved integration of the artificial intelligence will come, and ongoing trials on the biosensor lenses are going on. But whatever in hand we are having is the soft contact lens, mainly the soft toric, the RGP, which is the mainstay of correction of irregular corneas, piggyback system, hybrid lenses, and the scleral lenses. Soft contact lens, especially soft toric, will be of limited use, especially in early stage. In case of RGP intolerance, you can offer them, and you have to prefer stiffer or higher modulus materials when you choose a soft contact lens. Also, custom soft toric lenses are available. They have a thick optic section for masking the corneal irregularity, and you can increase the thickness of the optical zone as you increase as the degree of the corneal irregularity increases. Examples are KSOS and Novacone. Then this is the RGP, typical RGB fit. This is the most preferred lens fitting method, that is the 3-point touch. The weight will be distributed over the entire cornea. And if the patient is RGP intolerant and if there is apical scarring and all, you can prefer rose-K lenses, which are most prescribed gas permeable lens for keratoconus. They have different curves on the back surface so that the lens touching on the apex can be avoided. The feather touch on the apex can be maintained. And also this figure shows a piggyback lens. The patient is wearing a soft contact lens and over that an RGP is fitted for better vision. The disadvantages are you have to manage both the lenses and there is high risk of hypoxia because in your eye 2 lenses are there. And also this hybrid lenses are there, as this photo shows. Multifocal aberration control designs are available. Example are Synergize hybrid lens. Scleral contact lens is also widely used nowadays because it can be used in advanced cases since it rests on the sclera, reduced apical scarring because it does not touch the cornea, and it offers better stability and comfort and can delay the need of surgery because nowadays only 1 in 4 or 1 in 5 patients of keratoconus are undergoing surgery because of these new contact lens techniques. Different scleral lenses depending on the different diameters are available, like the corneoscleral lens, semi-scleral, mini-scleral, true scleral lenses, and the 3D printed scleral lenses are available. And here the vault is independent of the base curve radius and it is precisely predictable. So this is a very good option for highly irregular corneas. So concluding my talk, contact lens advancements have expanded the therapeutic options for keratoconus, but careful patient selection and customization are the key to success. Future technologies promise even better outcomes.
Thank you. So contact lens is always an additive advantage over any kind of refractive surgeries for patients looking for better quality of vision. So it's always better before going for any kind of negative treatment or response to the patient, have a contact lens trial done. Right from RGP to scleral contact lens, patients from CF 1 meter to 2 meter have resulted a vision of 6.9, 6.6 because of scleral contact lenses. Hence, before telling the patients to go in for a keratoplasty, it's always better to go for a contact lens trial and then decide for any surgical rehabilitation. Thank you. Thank you. So, unfortunately, Dr. Preeti madam, who was supposed to speak on CARES, and Dr. Sanjeev sir, who was supposed to speak on keratoconus, was not able to make it to the conference. So, I'll be taking over the topic. So, those who are not ideal for contact lens, whose vision is not improving following contact lens trial, are the ones who would prefer for keratoplasty in keratoconus. So as you can see, this is how it is. So if you are going to remove the entire cornea, it is called as a penetrating keratoplasty or optical keratoplasty. If you are only going to alter the upper 2/3 of the cornea, it will be called as a deep anterior lamellar keratoplasty. So indications are poor vision recovery with contact lens, intolerance to contact lens, healed eye drops or severe scarring, advanced keratoconus with apical scarring. So benefits of doing a partial thickness versus a full thickness is that there is no endothelial graft rejection, which is the most dreaded complication. Early visual rehabilitation because the endothelium is intact and the suture removal can be done faster. Better biomechanical support because it is not an open sky procedure, because of which we are not altering the glaucoma aspect. Extraocular procedures, extraocular like avoids open globe complications as mentioned, suprachoroidal hemorrhages if you are doing a DALC over PKP, and shorter course of steroids. So, preoperative evaluation is the ocular surface analysis. Topography has to be done in these patients. Ideal pachymetry has to be taken because we need to find out where there is scarring and where the cornea is intact. Axial length and IOL calculation, because if we are doing a deep anterior lamellar keratoplasty and it gets converted into a PKP, always a backup IOL is very important. Now, when we do a topography, it's very important to see that the pachymetry is pretty decent, not less than 200 microns, because then it becomes difficult to operate. So this is the Sandeli's Fourier domain OCT classification. So in this case, when we are doing an OCT, stage 3, where maximum posterior displacement of the hyperreflectivity is seen, these are maximum where we can go with a deep anterior lamellar keratoplasty. Anything more than this with a full thickness scarring, it is always better to go for a penetrating keratoplasty. So DALC techniques are divided into the manual DALC, a layer by layer technique. This is normally safer for beginners because we can decide the depth up to which we are going and the perforation chances are very, very less. Now to have a much better visual acuity in the patient, the Big Babar Anwar's technique